This brief narrated PowerPoint presentation will introduce you to the topic of somatosensory evoked responses, often called somatosensory evoked potentials. They're abbreviated SSERs when the term response is used, and SSEPs when potential is used. But I'll refer to these as responses since we've been talking about all the other responses using that term: auditory brainstem response, auditory mid-latency response, etc. As a rule, some audiologists use the word potentials, electrical potentials or evoked potentials. Um, all neurophysiologists do, pretty much, and neurologists. But I prefer the term responses because if you use potentials for some of these responses, I just used the conflicting terms right there. If you use the term potentials, then when you get to the auditory brainstem response, what do? Call it an auditory brainstem potential? Now, it used to be called brainstem auditory evoked potentials or brainstem auditory evoked responses. But Hal Will Davis, back in 1979, made a recommendation that the word response be used rather than potential. And it's certainly more easily understood by most people. Now, this is going to be a brief narrated PowerPoint presentation. I doubt that it'll be more than half an hour. And I'm going to introduce you to this topic. It's part of the curriculum, or part of the syllabus rather, for this course. And whether or not you will ever record somatosensory evoked responses is unknown, of course, but it's likely that you won't. But some audiologists do, and I certainly have, and I'm going to tell you a little bit about how that happened as we start off the PowerPoint presentation. Audiologists began recording, some, I won't say all, and certainly not all, and a very small number really, began to become interested in somatosensory evoked responses, or at least be asked if they could record them back in the 1980s. Now, why the 1980s? Well, I mentioned in the lecture on electroneuronography that in the 1980s, audiologists, some of us, mostly people in medical centers, were asked to perform electroneuronography, even though that's not something they ever studied in school and had never been done by audiologists. And the reason we were asked very often was we had the equipment, we had evoked response equipment, which could be used to record electroneuronography. And the same was true for SSER. If you've got a piece of equipment that can be used to record electroneuronography and it's an evoked response system, you definitely can record SSER. So a lot of times audiologists were asked to record SSERs just because they're in the right place at the right time, really. And they were also at that time, and you will learn about this in another lecture, audiologists in the 1980s were beginning to become involved in electrophysiological monitoring during surgeries. It's called intraoperative neurophysiological monitoring. And again, really the same reason. We had equipment that could be used to monitor patients who were under anesthesia in the operating room and who were undergoing surgeries that might put some part of their nervous system at risk, either the ear, the auditory nerve, or the brainstem, or in the case of SSERs, perhaps the spinal cord. Now, that's the way most audiologists got first involved in SSERs. I'll tell you my story in just a moment. So here we had a new electrophysiology in clinical audiology was very new at that point. You know, the AVR was discovered, as you know, in 1971, but it really wasn't until the 1980s that you could actually go out and buy an auditory evoked response system. And so it was really in the 1980s where audiologists, at least in medical centers, we're beginning to learn more about electrophysiology. And once you understand the principles, and you'll see when we talk about the SSER protocol and analysis of results, it's very similar to any other evoked response. In fact, sometimes they're called sensory evoked responses. You see the title of this chapter that I wrote with a colleague of mine, now deceased, a neurosurgeon, sensory evoked responses. So if you can record one evoked response, essentially you can record them all, although it does take a little more practice to record individual responses. You have to learn more about the stimuli and the anatomy. The basic concepts and principles are the same. Actually, among the sensory evoked responses, and the big ones are auditory evoked responses, somatosensory evoked responses, and visual evoked responses. Among those three, by far the most challenging and difficult are the auditory because the stimulus is so much more complicated. So that's what happened in the 1980s. People had the audiologists had the equipment, they were interacting, and if you're in a medical center, you're going to interact with neurologists, neurosurgeons, other types of surgeons, like orthopedic surgeons. So, you might run into them in a hallway or stairwell or at lunch or at a meeting, and one thing leads to another. And that's my SSER story, basically. Um, it started in about 1981, and I was at the University of Pennsylvania. It was my first major job as a PhD after getting my PhD. And it's an Ivy League university in Philadelphia, as I think most of you know. And I was directing a very small audiology clinic. I think there were three audiologists plus me. It was well established, had been there for a long time, and we were providing traditional audiology services, including dispensing hearing aids, a lot of diagnostic work. We were just beginning to get involved in cochlear implants at that time, and so it was pretty straightforward. Our newborn hearing screening was just starting. Hadn't really gotten off the ground at 1981, but we were seeing quite a few infants. Um, and one day I went to a conference. It was a conference for audiologists and speech pathologists. It was kind of a hospital based. This was the hospital of the University of Pennsylvania. They call it HUP. It was just kind of a required meeting of heads of departments in clinics, and I was the head of chair of audiology. And there was another, audiology was separate from speech pathology for the most part. So there was another person there who was a speech pathologist. And after this meeting, this person came up to me, speech pathologist, and she said, I understand you do record auditory evoked responses. And I said, yeah, we're real excited. We got some new equipment in our clinic. And, I was doing this during my PhD and when I was getting some clinical experience at Baylor College of Medicine. So we're among the first in town to do it. There was just one other group up at Temple University, which is also in Philadelphia, that was recording auditory evoked responses. She said, well, the reason I'm asking you is I'm married to a radiologist. He's a cerebral blood flow guy. Walter Obrist was his name, and he's part of a big research team involving mostly surgery, and I think they'd be very interested in talking to you. Would you agree to that? And I said, sure. So next thing you know, I'm sitting in the office of the chair of neurosurgery. Thomas Langfit was his name at Penn. Big, huge office, very comfortable couches and chairs, very well appointed. Of course, the chief of and the chairman of any department usually has a pretty good office, but neurosurgery is, among the highest ranked surgeons in any facility. And it was a great group of people, and there was a young neurosurgeon there that introduced himself, and Tom Generelli was his name, and I just found they really were interested in what I did. Well, it turns out they had a multi-million-dollar NIH grant, which had an experimental component in the lab, and then it had a clinical component, and they'd gotten they were given over $100,000 to buy this and build this big evoked response system, which includes somatosensory evoked responses as well as auditory and visual. And the whole goal was to monitor patients who were in coma after a severe head injury in order to predict their outcome and also to manage them more effectively. In other words, to determine which patients needed more intensive care, et cetera. And I found that very interesting. And I never recorded somatosensory, but I was, competent in recording auditory. So they asked if I would be part of this grant and go to the neurointensive care unit where the head injured patients were and monitor these responses there, and also do the same in the laboratory. So I spent quite a bit of my time doing that, and I got to the point where I really got quite interested in it. It wasn't traditional audiology, but you were making a huge contribution to the lives and management of these severely head injured patients. So that's how I got involved in. Right after that, after a couple of years at Penn, I went back to Texas, but this time to the University of Texas Medical School in Houston, and I went right to the chair in neurosurgery there. Of course, they knew the guys and the people in at Penn, and I immediately picked up where I left off and left off. And this article here was published after experience with hundreds of patients that we evaluated in the neurointensive care unit, all in deep coma. So different audiologists got involved with these non-auditory evoked responses in different ways. The readings for this topic are not very extensive. It's a small part of this chapter, chapter 7, non-auditory evoked responses. This is the same chapter that also includes the discussion on electroneuronography. And then this article here, it's optional. You don't have to read this, but if you want to, you can. You can always download it in case you want to refer to it later. But it's a review of how somatosensory evoked responses are used in clinical practice. My coverage of the topic in that book, chapter 17, that I just mentioned, almost focuses entirely on the use of SSERs in monitoring and diagnosing central nervous system diseases and disorders in head injured patients, whereas this article talks more about the use of evoked responses in general, and particularly in a clinical setting. And almost always neurologists or a neurophysiologist are using these responses, occasionally psychiatrists, but it's almost always neurologists. All right, well, now we're going to quickly talk about the anatomy and physiology, and this will probably be a bit foreign to you because obviously most of your anatomy and physiology coursework has focused on the auditory system, or maybe speech and hearing in undergrad. But here we're going to talk about a different sensory system. So we're not talking about stimulating the ears, and we're not talking about using acoustic stimuli. We're going to be discussing stimulating other nerves, long nerves, that are involved mostly in controlling your extremities, the upper extremity or lower extremity. And the stimulus that we're going to be talking about is not a sound, it's an electrical stimulus. It's a tiny little electrical shock, basically, and essentially the same kind of stimulus that we discussed for electroneuronography. So there are two general ways to record somatosensory evoked responses. My experience is entirely with upper extremity because I was interested in the brain, and we were, again, monitoring and evaluating patients with severe head injury. But if somebody is monitoring a person undergoing back surgery, let's say they're having a very delicate surgery in the lumbar spine to decompress nerves and attempt to reduce the pain the person's having in their lower back, then you would be using lower extremity SSERs, which I'll talk about in a moment. But the upper extremity SSER, of course, can be used to evaluate peripheral function involving the arm or the shoulder, as well as the central nervous system. So you stimulate the median nerve of the wrist, and looking at this figure, there's a guy standing there with his left arm up a little bit. That's where you stimulate it. If you go to your wrist, if you were wearing a watch, it would be just underneath the back of the watch. There's some tendons there, and there's a nerve that runs right near the surface, near the skin, the surface of your wrist on the inside that's going toward the palm of your hand. And so you would take a two-prong stimulator. There's always an anode and a cathode, just the same kind of stimulator we'd use for the ENOG, or you could take two electrodes and just tape them there. One would be the anode, is always the positive electrode. It's like the battery of your car. So that would be the red one. And then the cathode is the negative terminal or negative electrode, and that's usually indicated by black, or the negative sign and the positive sign for the anode. And the way I always remember that is anode starts with A, and you want to get an A plus in your course. So A is positive. Now, when you stimulating the nerve, you might wonder, well, how do you know whether you're actually getting a proper stimulus, that you're actually over the nerve? You know, the person's not going to be able to tell you necessarily. They may be comatose or in the operating room they're anesthetized. Well, this nerve that you're stimulating, the median nerve, runs all the way from the hand all the way up to the shoulder and into the spinal cord. But it's actually, most of the time you're not trying to use this median nerve um, to sense something, to feel something. It's actually the nerve is being used to move your fingers and move your hand entirely and move your thumb. And so it's more of a motor nerve, kind of like the facial nerve. And so when you stimulate with an adequate stimulus, which is a little electrical shock presented very slowly, 1 per second, maybe 1 every 2 seconds, you can see the thumb twitch. The thumb will twitch every time there's a stimulus. And that's what you use. You keep presenting the stimuli at gradually higher milliamps, gradually higher levels of current until you start to see the thumb twitch. So you're basically, it's kind of an interesting thing. You're basically going the wrong direction on the nerve. It's like going the wrong direction on a one-way street, because the median nerve mostly is sending information from the brain, from the parietal lobe, from the motor area of the brain, out to the hand to control what your hand does. And of course, this is a very well-developed system. You can use your hand for writing, playing music. You have very, very performing surgery. So you can do fine things, fine motor things with your hand. So it's a very important nerve, and it gets a lot of use. But we're actually running our electrical signal up the nerve the wrong way. I mean, it goes both ways. So it's going up the nerve instead of down the nerve to the hand. It's going from the hand up to the brachial plexus, which is a collection of kind of a junction of nerve fibers. It's kind of like an intersection. So you've got nerves coming from the shoulder, nerves coming from the hand, nerves coming from the other regions in that area. The armpit, probably a little bit from the back, all coming together, and then the nervous impulses go into the spinal cord, into the dorsal columns, the dorsal fibers in the spinal cord, and then up to the brain stem and to the cortex. So that's where we're stimulating. And when the information, the neural impulse, gets into the spinal cord, it goes zipping up. Now, of course, with the upper extremity, it's not in the spinal cord really much at all, because the next thing you know, it's in the brainstem. And there are brainstem centers for the somatosensory system that are right in there with the cochlear nucleus and spiro-olivary complex. Remember when I talked about I think it was Enog, I was talking about this neuroscience course I took, and I remember distinctly looking at slides, cross sections of the brainstem, and being amazed at how close all of these different nuclei are, the different auditory nuclei, and of course somatosensory and vestibular, etc. So we don't need to remember the anatomy in great detail, but remember that there are centers in the brainstem where the somatosensory response is being processed and it's being transmitted, and that goes up to the thalamus. So in many respects, and this is again the same principle I just mentioned, if you know one evoked response, you know them all. If you understand ABR and middle latency, you just have to basically transfer that knowledge to a different type of stimulation and slightly different anatomy. So whereas with the ABR, we've got generators in the midbrain region, and we've got a generator in the lateral lemniscus, that's wave 5. For the somatosensory, we've got also generators in the same region, but it's the medial lemniscus, not the lateral lemniscus. And then when we get up to the cortex, or not before we get to the cortex, we get to the thalamus. Well, the auditory part of the thalamus is the medial geniculate body, which is in the posterior region of the thalamus, but there's also a nucleus for the somatosensory centers in the thalamus. And then, of course, there's a cortical part of the response, cortical component. For the auditory system, it's primary auditory cortex. In the temporal lobe, somatosensory, it's a comparable cortex in the parietal lobe. So that's pretty much all you need to know. And I'm going to get to when I get to the lower extremity SSERs, and here we are. Now we're stimulating the tibial nerve, which runs up the leg. These are long nerves. I mean, when you think of the auditory nerve, it's only going from the ear to the brainstem. And if you look at a skull, you can pretty much see we're talking about just a few centimeters, very, very short distance. Obviously here, you're the nerves are much longer. One nerve is going all the way from the fingers and the hand all the way up to the shoulder. And the lower extremity, it's going all the way from the toes and the foot all the way up to the spinal cord up near the hip. So these are long, long nerves. And interestingly, the latency of these responses, although they're all roughly the same, the latency is definitely related to the size of the person. So the latency in a child, say a 3-year-old, is much, much shorter than the latency in a full-grown adult. And then if you're, evaluating a person who's 6 feet tall, the latencies are longer than if the person's 5 feet tall, for example. So with the lower extremity, same basic concept, but the nerve is different. It's a tibial nerve, not the median nerve. And of course, in the ankle, there's not much fat there. So you can get to the nerve very, very easily. It's just underneath the skin, between skin and bone and cartilage, just like it is on the wrist for most people. So the pathways are very different for the lower extremity as to get to the spinal cord. And of course, all of the spinal cord pathway is unique to the lower extremity. You don't find that with the upper extremity. But once you get up to the upper parts of the spinal cord, the lower extremity pathways are very similar to the upper extremity pathways. They both go through the brain stem and through the thalamus, and of course to the same part of general region of the brain, the parietal lobe. So again, I never did any somatosensory evoked responses during back surgery or with orthopedics or neurosurgeons do back surgery. Of course, they do a lot of important back surgery, but I was never involved in that. That was always just a little too far away from audiology for me. But I did perform the upper extremity because I had the equipment, and very often I was also evaluating auditory responses in the same people. All right, now when you review this PowerPoint, this is an important slide because it identifies the anatomy of each of the major components. And again, don't try not to get too concerned about or worried that, oh my gosh, this is totally new information. Think about it like a variation of the ABR and a variation of the middle latency. So you've got a component, the N9 response, which is you measure it by putting an electrode on the clavicle, usually off to one side. You're usually stimulating the right wrist. If you're interested in evaluating the arm, say nerve entrapment, say a patient's got nerve entrapment and they're unable to move some fingers, and you wonder, well, is something wrong with the nerve somewhere between the fingers and the shoulder? Then obviously this would be a very important response, the N9, because it's telling you that the information came from the stimulus site, which would be the wrist, if it's upper extremity, to that part of the brachial plexus before it goes into the spinal cord. So the N9, it's not really comparable directly to an auditory response, but it's sort of similar to the wave 1 of the ABR. It tells you you're getting a stimulus. And then there are components of 14 of P14 and 15 or 13, 14 sometimes. It depends on these are just rough latencies because it depends on the size of the person, like I just said. That now we're getting into the brainstem. And this would be considered kind of like the wave 5 of the ABR. And then we move further up, we're getting a response from the thalamus. That'd be kind of like the middle latency. And then or at least part of the middle latency, the NA part of the middle latency. And when we get to the cortical responses, and again, the latencies are approximate, but they're pretty much the same general latency region as the middle latency response, which makes sense. In a sense, it makes sense because they're coming from the same parts of the brain, although obviously the middle latency auditory response doesn't have to cover anywhere near the distance getting from the ear to the brain. So again, be generally familiar with the anatomy of the SSERs, but mostly I want you to understand their analogy or their similarity to the ABR. Okay, very quickly, test protocol, and we're getting close to the end here. I'm going to just review the test protocol, and you're going to see that it's to a large extent similar to ENOG. So, again, in the 1980s, I readily told my chair, Bob Jarsdorfer, chair of otology at the University of Texas, sure, I can record ENOG, even though I'd never heard of it. And, we learned how to do it pretty quickly. Once that I was doing ENOG, the SSERs, weren't that different. Of course, I was also recording SSERs a few years before that at the University of Pennsylvania, but the concepts are so similar. And as an audiologist, used to having to deal with auditory stimuli and latent and the duration of the stimulus and making sure that the stimulus was there wasn't any distortion. It was the proper intensity. It was the proper stimulus click versus tone burst, etc. Going to a simple electrical shock is very simple. I mean, it's always the same. It's always an electrical shock. So we're not going to go over this in great detail, but again, look at the PDF of the PowerPoint or go back and listen to this again. But you'll see that we're using electrical shock. It's a very low amperage, but the number of milliamps, the intensity of the electrical shock really will depend on what you need to get a proper response. And of course, you document it with the upper extremities on movement of the thumb, and lower extremities, usually you'll get movement of the toes. And you need an analysis time. Well, the rate is very slow. The polarity is not that important, but the rate has to be very slow to give the nerve a chance to respond. These are big responses, typically, reasonably big, so you don't need, it's kind of like recording the middle latency. You don't need thousands and thousands of stimuli, so it goes pretty quickly. The analysis time needs to be long enough to encompass the entire response. Again, if you use an analysis time that you'd use for middle latency, it would be quite appropriate. Filter settings, quite similar. But where you put the electrodes, obviously, very different for SSERs versus auditory responses. Here, we're putting electrodes where we know there's going to be activity under the electrode. So, like the brachial plexus, well, that's kind of like the cochlear nucleus. If you stimulate the ear, there's got to be activity in the cochlear nucleus. You can't bypass it. All the eighth nerve fibers, that's where they synapse in the cochlear nucleus. And the same thing with the brachial plexus if you're stimulating upper extremity SSERs. The nerve impulse has got to go through there, and so you're going to pick it up because it's another bony area where the electrode's just over the actual neurons that are being recorded. Now, once you get into the brainstem, obviously the electrodes you put on the scalp, and very often you'll be an electrode on the back of the neck or somewhere reasonably close to the lower brainstem generators of the SSER. And then, of course, you have electrodes up you can put them on the top of the head, CZ, or even on the forehead. Once you start recording the actual cortical responses and thalamic responses, you can record them anywhere on the head. So, as with ABR systems nowadays, and even back then, once you set up your somatosensory evoked response system, you could just leave it that way. Although, if you're using a system that is used for both auditory, somatosensory, and visual, in the early years, you actually had to turn knobs. Every time you wanted to record a different type of sensory response, you had to set up the equipment totally differently from the way it was. So here we have the responses, the waves again, and they're linked to where they're recording. So the earliest wave, N1, is very often equivalent, say, to wave 1, and then we've got later waves all the way up to the cortical responses. Now, the lower extremity SSERs, obviously the latency is much different because the neural impulse is going to go all the way from the ankle, all the way up the leg, and then all the way up the spine before it gets to the place where the upper extremity responses come into the nervous system. So obviously you're going to have very, very much longer responses, but essentially they're equivalent. You've got a kind of a peripheral integrity response, that would be the brachial plexus, a brainstem response, and then cortical responses. All right, well, we're down to the last few minutes. Now we're going to talk about clinical applications. And this response is being recorded probably every day in every major city. This is going on a regular basis, usually in hospital settings where the neurology department has a EEG lab. And at the EEG lab, of course, they don't do just EEGs. They always are prepared and have the equipment to perform evoked response measurements. And so the somatosensory would be one of them. So what kind of patients would these be used on? Well, there's at the very bottom of this slide, there's the head injured patients that I was talking about. And a lot of this instrumentation, I was involved in some of the early research where we were actually trying to document that this really worked, like clinical trials. Could you really evaluate patients electrophysiologically who were comatose, and could you get valid results? Did the heavy sedation that these patients got, and sometimes they were put in coma to preserve. You remember all have heard of Damar Hamlin, the Buffalo Bills um, defensive back who had a sudden cardiac arrest playing on the field in Cincinnati, and he was put into when he was taken to the hospital in Cincinnati and was in the neurointensive care unit. He was put into an induced coma to make sure that his brain wasn't damaged from the disruption of blood flow to the brain. When you put in a deep coma, it slows down the metabolism of the brain so that it doesn't need as much blood and oxygen. And of course, obviously, he did very, very well. So very often these patients, not only are they comatose because of the head injury, they're also heavily sedated and they're given pentobarbital or some other deep, deep sedative. So there's no way people can know, can't ask them questions. They can't ask them to close their eyes. They can flash a light in their eye, look at a pupillary response, but some of those brainstem responses are actually suppressed by the heavy sedation and by whatever other almost anesthesia the person's getting at the time. So they're totally unable to respond in any way. So these responses are the only way you can know what's working and what's not working in their brain. So that continues to be an important application. And the bullet above that, neurophysiological interoperative monitoring, also is still a popular application of SSER. Usually it's done by technicians who are trained to do it, and the surgeon is obviously aware of what they're doing and how they're doing it. So their surgeon's usually their supervisor. So that's still being done, particularly on very, very delicate surgeries where the goal is to make sure that there's no more damage done. So the person may have paralysis or may have severe pain in the back. And so the surgery is trying to make them better, but they don't want to obviously make things worse. But then there are more clinical applications of SSER, and these are all, audiologists aren't involved in these. I can't imagine any audiologist would. These are all in neurology clinics or neurology labs. So there's the peripheral application. So you're stimulating the median nerve and recording from the brachial plexus and back of the neck, perhaps, and also the scalp over the parietal lobe. And these would be, for example, a person who's got very advanced diabetes and has peripheral neuropathies. So they can't feel their fingers, can't feel their toes. They have very, very poor circulation in their extremities. Or people where the nerve's entrapped for some reason, carpal tunnel syndrome, etc. And then there's others where the goal really is to evaluate the central somatosensory system, and that's more similar to what we were talking about earlier. So this would be multiple sclerosis. That's probably one of the more common diagnoses that's evaluated, just to find out which nerves are working, which ones aren't. Spinal cord tumors and injuries, and then of course degenerative diseases. And I've just got a couple of them here, such as ALS. This is just a short list. The reading that I mentioned earlier, the review article on clinical applications of SSERs, has many more. Well, that concludes our introduction to SSERs. Audiologists need to know about them, particularly if you're going to be in a medical setting. You need to know about any responses that are similar to yours, because very often you're on a team. And when you're on a team, you're sitting around a conference table, for example, and people are describing their findings for the patient, and somebody's there to, usually a physician who's overseeing the management, who's taken all this information to determine how it's going to help them manage the patient. So you have to know a little bit about what everybody does, as well as a lot about what you're doing. So I encourage you to complete the readings on quiz 4, which covers ENOG. There are 15 questions on ENOG. There are 5 questions on the SSERs, and there are 5 questions on interoperative monitoring. Okay, so that's the end of this narrated PowerPoint presentation.